Namaste and greetings from Bangalore to all the kidney warriors, your families, well-wishers, ladies and gentlemen. In the first place, let us all applaud and congratulate the team at KWF and its founder, Mrs. Vasundhara Raghavan, on their third birthday. I was really delighted to see several pictures of children on their website. It reflects ideology, pursuit, and integrity. Today, ladies and gentlemen, I'm going to share the journey of children on dialysis with you all. I'm Arpana Iyengar, pediatric nephrologist from St. John's Medical College Hospital, Bangalore. Imagine that you were in Disneyland and you see these two kids enjoying their ride. That'll bring a smile on your face. Now, if I tell you that these two children are on dialysis, you will surely have raised eyebrows. Yes, this boy is on home dialysis, also called peritoneal dialysis, and this girl is on machine dialysis, also called hemodialysis. So clearly, these children are nowhere near Disneyland, but unfortunately in dialysis land. Children love to play the game of maze. But what if life itself turned out to be a maze of paths, hedges, and hurdles? Today, I'm going to address 3 important points about children who are undergoing dialysis. When do children really need dialysis? When they are on dialysis, how do they actually manage themselves? And as the dialysis is going on, what next? Before we move on, these are some of the ground rules. Every kidney disease does not lead to kidney failure. And every kidney failure does not necessarily need dialysis. There comes a time when the kidneys exchange blows and reach a point of no return, and they really cry out for help. It's at that time that we need to support these kidneys artificially, either with dialysis or transplantation. You will observe in this graph that kidneys are really tricky organs. When the kidney function is 100%, you see that the child is totally healthy. When the kidney function comes down to 50%, there are no symptoms. That's treacherous. When the kidney function further reduces to 30 and 10%, one can have minor to major symptoms. What are the types of dialysis that we can offer children? Similar to adults, we have 2 types of dialysis, the hemodialysis and peritoneal dialysis. Coming to hemodialysis, we have children coming into the hospital 3 times a week with dialysis sessions going on for 4 hours per session. And these children have a tube which gets into the blood vessel, we call the vascular access, on the thigh or the neck. Some of the older children are on fistulas. We use a smaller dialyzer, we use shorter tubings. Most of these kids require blood transfusions very often. They have dietary restrictions. And as mentioned, they keep coming to the hospital so often that they cannot afford to go to school. So only 20% of our children who are on hemodialysis actually attend school. The cost per month comes up to 15,000 rupees. In contrast, this is an image of a child undergoing peritoneal dialysis, or also called home dialysis, and the cycles are done at home. Children are fortunate to have parents who could undertake this dialysis in them for 12 to 18 hours. It's timed such that they can go to school, they can have their evening play, and it is surely child-friendly. These kids have lesser chance of receiving blood transfusions, they have minimal dietary restrictions, and about 80% of our kids on this home dialysis actually attend school. However, the expenses per month is way beyond hemodialysis. It is about 25,000 per month. What do you see in this picture? You see a child lying on the bed, being dialyzed, surrounded by several adult patients, and her grandma is sitting beside her. You will agree that this is surely not the ideal way to treat this child. We should have pediatric standalone dedicated units for dialysis. and we created one with the help of State Bank of India just a couple of years back. It's not only about having a unit dedicated for children, but also a dedicated team that consists of a nutritionist, a renal nurse, a PD nurse, a hemodialysis technician, and a medical social worker. It is this team who also is engaged in outreach activities, home visits. They actually go to the homes of children who are on home dialysis. They go there to ensure that the child is being dialyzed the right way. You see, this kid is sitting on her bed in her bedroom, and the mother is undertaking dialysis. The medical team is beside her, trying to monitor, supervise, reassure, encourage her to do the dialysis in the right way. So clearly, it is evident that PD or home dialysis is a child-friendly dialysis modality compared to hemodialysis for the various reasons I've just mentioned. I recall a small incident, and I would like to share that with you today. It's about an 8-year-old boy who was our patient in end-stage renal disease. He was on hemodialysis for a few months and then was referred to us because his hemodialysis was not functioning well, and we shifted him over to peritoneal dialysis. A couple of months went by and he was comfortable on peritoneal dialysis, and I asked him, which dialysis was better? Was it hemodialysis or peritoneal dialysis? And in came the answer, peritoneal dialysis. That was expected. Then I asked him, why do you feel peritoneal dialysis is better? And in my mind, I thought that he would consider this as an advantage over hemodialysis because he was at home, he could eat better, he didn't have to come to hospital and look at the doctor's faces again and again. But to my surprise, you know what he said? The little boy said, PD is better than hemodialysis because mommy does it for me. What a heartwarming statement. What a genuine statement from an innocent child. I would now like to change gears and give you a glimpse of what major challenges children who need dialysis face in our country. Our country has a mix of health care institutions, a mix of public and private sector hospitals, and dialysis facilities for children is not available in all institutions uniformly. Take, for example, this government hospital has got the facility for both hemodialysis and peritoneal dialysis, but peritoneal dialysis is not free of cost. Take, for example, this government hospital. They do not have any child dialysis program service available. This multi-speciality private hospital has got all facilities for hemodialysis and peritoneal dialysis, but it comes with a big cost. And this private multi-speciality hospital has no service for child dialysis. So besides access to dialysis being a major medical barrier, let's just take a look at the non-medical barriers. It's all about attitudes of the family, the decision makers towards accepting this modality, towards giving the chance for the child to live. Decision making, traveling that long distance to the center that can offer dialysis, monthly income, occupation, education of the parents, and time of diagnosis. The earlier the kidney diagnosis is made, we find that families and parents accept treatment modalities better. There are some needs, besides medical needs, there are some non-medical needs, and that is awareness. Awareness that children are also vulnerable to kidney diseases. Children can also be treated with dialysis. Children can also do well with transplantation. Patient support groups who can share with each other their experiences and increase the strength and confidence amongst them to support their own children. Counselors, funding opportunities, remote monitoring and referral systems will go a long way to address the long distance travel. You'll be interested to know what parents speak, how they perceive, how they feel while they are undertaking dialysis in their children. They are filled with fear, misconception sometimes, and frustration. This is what one of the parents said. Hemodialysis is better, it's safer, done in the hospital, doctors are there. And the father who was offered peritoneal dialysis said, I am from a rural area, our house is not clean, I have a very small house, and I have cattle in the backyard. So I may commit mistakes. I think this dialysis is not safe. So these are some of the misconceptions that our parents have about undertaking dialysis, and this is not true. We've had many families coming from rural areas who are not so well educated undertaking dialysis very well in their children. And this is an opinion from a father who is from an urban area and who is successfully doing home dialysis. He said that he's very happy that his child is going to school, but he never anticipated that peritoneal dialysis could consume so much of their time and expenses. So caregivers' burden is really something that one should focus on, and they have disrupted lives. Only when you probe and try to find out, all these expressions come out. The father of one of the child on peritoneal dialysis said that we have lost the chance for recreation and social life, and we feel very isolated. We don't feel like moving out in society or even amongst our relatives for obvious reasons. Despite all these hurdles, there have been a number of individuals, philanthropists, and organizations who have stood by us, stood by our vision, stood by our children to make a difference to them. And I think today is the right time and day to express my gratitude to all these organizations who have supported us in the last 2 decades. And I must say this today, that we are looking forward to being part of KWF. We want to be associated with them closely in the near future. I'm glad to share some of the amazing achievements that our children on dialysis have achieved. This is a boy who got 86% in his 10th standard exam, and he was on peritoneal dialysis. You see, children are resilient. They fight back so well. This girl is a winner this year. Despite the pandemic, despite disruptions in her coaching class and moving on to online class, she has secured a very good rank in the NEET exam and has bagged a medical seat for herself. This girl's truth is that she got transplanted 3 years back. Yes, coming to transplantation. In children, we all should remember that dialysis is just a bridge to transplantation. The optimal treatment for end-stage kidney disease in children is transplantation. So we should have as short a period of dialysis for children and encourage all of them to move over to transplantation, because kidneys are waiting for that genuine help from another kidney. And children are really fortunate to have parents who could be potential donors. So you see in this picture, the parent's kidney, the big kidney, can be placed safely inside the child's abdomen, and the old dysfunctional kidneys stay back up there. This is a galaxy of beautiful children who have gone through tough and rough times on dialysis, most of them reaching the stage of transplantation and doing well after transplantation. I know that there are such beautiful people out there in the audience today, because these beautiful people have known defeat, have known suffering, have known struggle, known loss, and have found their way out of the depths. These people have an appreciation, a sensitivity, and an understanding of life that fills them with compassion, gentleness, and a deep loving concern. Beautiful people don't just happen. I would like to conclude with this last slide, which again shows the lovely kids who are sitting in the first row. These are kids who have achieved transplantation and are doing well. And in the second row, you see the beautiful mothers who have all donated their kidneys to their children. Yes, we find that mothers donate kidneys readily, And we always find mother being a donor commonly compared to fathers donating their organs to their children. And today I'm fortunate to have one such beautiful mom, Mrs. Vijayshri, along with her little baby, Jessica, on board with us to share her experience when she undertook dialysis, home dialysis, in her little girl. Before I hand it over to Mrs. Vijayshri, my sincere thanks to Kidney Warrior Foundation, the entire team, and everybody in the audience for giving me this opportunity, listening to me. And we, again, I would like to express that we would like to be associated with KWF as early as possible. Stay healthy, stay safe. God bless. Thank you very much. Over to Mrs. Vijayshri.
Hello, doctors. My name is Vijayshri, mother of Jessica. First, let me thank our doctors for giving me this opportunity to share our experience. When she was 1.5 years old, she got fever with eye swelling. So we took her to hospital. Then doctors treated her and gave medicines and told us to observe for 2 days. But her swelling didn't reduce. So we went back to hospital and they told us that we need to meet pediatric nephrologists. So we came to St. John's. Then we showed to doctors where doctors gave us a Vislon medicine for about a month, which Jessica didn't react for that. And finally, they did few tests and they told us that kidney failure, and she has to go for dialysis. So we were discussed about both PD and the peritoneal dialysis. We were discussed and the hemodialysis. So it's like PD dialysis where we can do at home, and the advantages are more were there. So we accepted peritoneal dialysis. So they did small surgery, and we were trained like how to do the PD at home, about the sanitization, and about the observation of the child. They told us. Then when like after hearing all those, we were like shattered, and we were very low. We don't know what to do. By then doctors consoled us so much, and they guided to social workers. They told everything, like how to take care of the child, how to do home dialysis and all. Then after surgery we went back home. We started doing cycles at home. So as a mother, I had many, challenges, many thoughts behind running behind me, where how she will handle, how she will take care. Then like at home, my I have an elder daughter also, where she used to run, play, uh, go around. So by seeing her sister, even she wants to play.
5, 4, 3, 2, 1.
When she was 1.5 year old, she her kidneys were failed, and we started with peritoneal dialysis. Uh, we choose for PD because we can do at home easily. So we started PD at home, where we took lot of care at home, where sanitizing, we did sanitizing, we sterilization part. Every doctors have informed us. When we used to do PD, like she wants to play, run around. So we had a intervals of like 2 hour cycles we used to do, where I used to sometimes disconnect and make her play. And sometimes, as we live in apartment, she wants to go for birthday parties. Where that time I used to fill for two bag, and I used to send her for birthday parties, where she used to be very happy that time. And my she used to play with her sister also. When she was doing the cycles, she used to carry the bag and run in the around the house. And it was very easy also, where we don't need to spend more time in hospital, where she can be at home happily, and she can be safe. This is how the PD worked for her for about 3 years, and we transplanted her, and now she's very happy and she's going to school. Thank you.